Davudu. Thanks for being the first to join. Hi guys, so welcome to yet another edition of the Call of Duty. I'll wait for a little bit more before I start with an introduction of myself. And obviously before we then pull in the Commissioner for Health from Kaduna State. So let's just give a bit more time for other people to join before I get into introducing myself to you guys, for those who may not know me. Okay, I think it's 5 o'clock spot on. So we can spend the next few minutes just introducing myself, but also setting the ground rules for how I'm gonna try to run this. For those who may not know me, my name is Bosun Tijani. I'm the CEO and co-founder of CC Hub. So CC Hub is Co-Creation Hub, which is a technology innovation center that is based in Yaba, but with operations in Abuja, in Taisholang University in Ijebode. We also have a center in Nairobi in Kenya, and also a design lab in Kigali in Rwanda. Our goal at CC Hub is really to see how we can power innovation to solve some of the serious problems on the continent. And today I've been given the responsibility to actually interact and help learn about the amazing work that the Kaduna State government and the leadership in Kaduna has been doing around this unfortunate pandemic that we all have to manage. And I think with us today is the Commissioner for Health, Dr. Baloni. I think, someone who I can say is, again, well prepared for this position. She's a medical practitioner with a master's degree in public health, which I think can be a strong addition to that position. She also has very strong background in management as well. She's been trained at the INSEAD School of Management, but also along that side, not just in management, she's also quite strong in epidemiology, which is one thing you need at a time like this. So the way I'm going to try to run this, before we call on the Commissioner, I can see that the Commissioner is online. Commissioner, I'll need you to request for me to allow you to join the conversation. There's a button which you can click on that will let you request to join the conversation. If you can please click on that button. It should be quite close to the top of where you have your comment space where you can comment. So you see the button there. Once you click on the button, I'll be able to add you to the conversation. So I'm going to spend, we have 1 hour with the Commissioner luckily, but what I'm going to do is to try and spend about 30 to 40 minutes just asking a set of questions, some that we've obviously curated, but also some that I personally find extremely important. But on top of that, I'll then have the opportunity to ask questions. We obviously won't be able to take all questions, I'll urge you to use the question feature. If you ask a question, comment, I won't be able to see it. So please do use the question feature so that I can see your question. And that way the Honorable Commissioner will be able to then hopefully answer some of these questions. I can see that the Commissioner is on board now. Dr. Baloni, thank you so much for taking out the time to join us.
Just talk. Yes. Good afternoon, everyone. I'm glad to be here.
Thank you so much. We appreciate that this is a difficult time for all of us, but most importantly, I think for a commissioner for health. I don't think it's almost like being the Minister of Defense in time of war. So I can imagine this is a difficult time for you in person. And you know, I'd like to, the way we'll do this is I'll probably ask you a few questions just for about 30 minutes.
Okay.
Then we'll hopefully talk to a lot of our followers to also be able to ask some important questions to you. We hope you can indulge us and answer some of these questions. Whichever one of them you don't feel comfortable answering is okay. That you leave them. But what we want to do is to really help our people understand how much the leadership is doing at a time like this. This pandemic is not something that any of us alive has witnessed before. It's a difficult one for both us followers, but also you guys leaders as well. So we quite appreciate the work that you've been doing, you know, alongside your colleagues from all the other states in Nigeria to keep all of us safe. But I'll start with this question, Doctor. What does it feel like to be a commissioner at a time like this?
Okay, I haven't had time to think about that actually.
Sure.
There's a lot going on, so it's not something that you ponder on. My role is to try to coordinate the health sector in general, and as well as the health sector COVID response, make sure that we have a robust plan, be prepared for any eventualities, and with try to get as much support and collaboration from all players. So we have a multifaceted emergency operations committee, and we have co-opted all experts from the primary, from the secondary and tertiary institutions and academia, and we're trying to give it a team approach to see how this can work. So this is what we're trying to do.
So your role is in coordinating all these different stakeholders, different institutions, just to make sure that, you know, they can be there for the state, right? That must be really difficult, right?
Well, I think the players have all been very excellent. Everybody is willing to really contribute ideas, expertise, time, and knowledge. So it's a good one. It's a bit of a challenge because you're being pulled in different directions, but it's something that I think the team really has been quite supportive, and we've tried to approach it in that manner. And also we have very strong support. The governor has provided unprecedented support and political will to take those difficult decisions that I think many people are shying away from. The deputy governor is a public health practitioner herself, and she's also been very strong, a strong supporter, and we collaborate together and jointly lead the response. So it's something that as we learn, we go. We're learning from other people. We're learning from ourselves. We're watching the guidance from NCDC, from other world bodies, and trying as much as possible to put it in the Kaduna state response.
So you mentioned difficult decisions there, and I think definitely this is a time where leaders have to take difficult decisions. On the 1st of May, I think at the platform, the governor mentioned that this has been a situation where the state had to take a decision between lives and livelihood at the onset of this pandemic. And I think that's something that has been a source of major headache for leaders, not only in Nigeria, but in places like the UK or the US as well. Would you say that that decision, as difficult as that might have been, that's probably responsible for also where we are in Kaduna State today in terms of the spread of this virus?
Yes, I agree 100% with him. It's a delicate balance. We all know that a lot of our people have challenges. A lot of them, have to go out daily to feed or to look for what to feed on. But we also know that as challenged as our health system is in this country and across the states, if we get to the point that we cannot respond to the disease, then we will really lose a lot of people. Everybody has seen the statistics going on in all countries in the world that have the most sophisticated healthcare and what we're aspiring to be. They cannot cope. They're inundated with patients, inundated with lack of equipment. Some of them have challenges with PPEs. So the best option left for us that have challenged health systems is really containment, to try to flatten the curve, which means that we reduce the number of people that are interacting or getting the disease and interacting with the health sector so that we can better prepare and also respond. And I think that early decision we went on lockdown before the rest of the country did. That early decision helped us. Unfortunately, we had an influx of people and the cases spiked up. What we've noticed is even in all our cases, all of them had travel history to the initial cases to states that were affected. And a large proportion of them are contacts. So we have like over 70 of our cases are contacts of cases, primary cases. So you can see that we are succeeding in stopping the population from getting it. We also have to try to stop this interstate. Yes. Which is something that we're taking very seriously because that is our greatest risk.
So I guess you're probably also alluding to the fact that the repatriation of the Almajiris from Kano probably also contributed to the number. Kaduna State is at about 170 cases now. Am I correct?
Yes, it's about 170 cases now. 767 of those were Almajiri. Tested positive. When we got the repatriated Almajiri, we decided that we will hold them as we should in quarantine for 14 days before we let them into the communities. In the first instance, we screened them nutritionally and health-wise, and we found 8 or 10 of them that had symptoms suggestive of COVID, and we took the decision to test them early. Once we got 5 of them positive, considering that they were already in the same place and had been traveling together, we now started testing all of them. By the time we finished the testing of the 157, we found 67 were positive.
That's hard.
Yeah, we've also received Almajiri from other states. We have also quarantined them and screened them, but so far we haven't found any positive. So as they're coming in, including travelers that we have stopped from coming in, we have quarantined over 55. We've discharged the first group of 28. We found 2 positive, which we've transferred to the treatment center. We're watching the rest and screening them. So it's very important that when people are coming in, we observe those guidelines because we don't want people getting into the communities and spreading it. As you know, a large percentage of COVID-19 patients are asymptomatic.
Absolutely.
So yes, so if people are coming in and getting into the communities and are asymptomatic, we'll have silent community spread. And by the time it blows up, we will not be able to manage it. So we're looking at that as well, to see that we cover those bases.
So containment has been a strong success factor for Kaduna State, then, based on what you've just shared.
Yeah.
Is that correct, Doctor? Okay. So coming from there, you mentioned something which I think is also quite big in this whole pandemic, which is
right.
the strength of the public health infrastructure itself within the country, but also in states as well. There's a stat that, again, correct me if I'm wrong. There's a stat here that I believe is from MBS that says the doctor to patient ratio in Kaduna is about 1 to 4,634. Is that correct? So with what we've seen with this pandemic, is that a strong alarm for us to consider, investing heavily in capacity?
Yes, of course. Before this pandemic, in fact, we had just finished a recruitment process to employ 3,000 staff into the public health sector role. And the recruitment had been almost completed. We're just waiting to get the successful candidates when this happened. So, of course, there's a freeze on all new employments and things like that. But in the last 3-4 years in this government, the government has consistently met the 15% allocation of funds to healthcare. The government has embarked on renovation and upgrade of 255 PHC facilities, one in every ward. We're looking to equip them. All the secondary, we have a program to upgrade the secondary health facilities, and also to do we did an analysis of the gap in human resource, and we were just moving to address that, which of course we hope we will do in the future when we've stopped dealing with this. But we're fully aware of this, and one of the cardinal agenda points for this government is to revitalize the primary health care and make sure that also the public health service is responsive to healthcare needs of the people. We've also got a contributory health scheme, which has just flagged off to reduce out-of-pocket expenditure. And there's a special fund for vulnerable populations. So it's all in the plan. COVID just slightly derailed some of those plans, but we're also looking at what we can fast track to support the COVID response before we move on with that. Thank you.
Absolutely. And where would you say Kaduna State is at the moment in terms of the curve? Do you think it's coming down? Are we flattening it? What are you seeing?
If you look at the spike that we had, if you remove these were a group of people that came in and we had to test, and we, of course, probably if we had let them into community, we would have picked them up later. But if you look at this, without that injection, the spike, yes, we've had an upward trend of cases. But if you also look around all the states around us, you will see that the increase in cases is much, much higher than we have. And we attribute it to some of these measures that we've taken. It's as you get cases and as you test more, you will pick up. So you will have a spike. But we hope that this will now further fine-tune our strategy. So for example, now we've done a mapping of all the communities in which we have cases. We've elucidated a testing strategy. We will start testing within contacts of those patients in those communities, and then wider in the community, so that we pick up any community transmission that may be going on there, and that will now help you to target your public health response better to those places. You may decide to do differential lockdowns if it shows that, you know, this cluster, we do a few wards and we find out that it's only in a particular place it's circulating, then, you know, we can sort of target the response that way. So we're looking at the data. We're looking at the test. Yes.
So that's what my next question was going to be. That do we have access to enough data to be able to project and calculate rate of infection, for instance, and to then be able to say, you know, these are where we expect that this will be growing in terms of infection. How are you managing this? And this is not even, you know, singling out you as the leader. I think the system in itself is not being where we expect or would like it to be, right? And that would impact your ability to then
be able so to if you do
a lot of the things you're talking about. Yeah, go on, doctor.
Yeah. Okay. You were
yes. I think.
Okay. So if I get you correctly, the data we have is what we're working at. And so far, we've done about 1,000 tests as of today, and out of them, we have 172, like you said, positive. Of course, as we do the treatment, we're also looking at, you know, you retest people. So some of these tests are on the same cases, just to make sure that they've exited they're no longer excreting the virus and you can discharge them. But we are, if you do a quick and dirty, like of what I said to you, we had 12 cases. Primary contacts were about 40, and secondary contacts were another 30 something. So you can see that if you look at 12 to 40 is about 3. One person infects about 3. So it still means it's quite high. We're aiming to go down to one person or less than one person for you to say that the rate of infection is not growing. But also, if you look at that data closely, it's in clusters. We have one family that have 10 cases. So out of those, it's 3 or 4 family clusters. One has 5, one has 10, a few have 4. So it's not, there are some people that within their contacts, there's nobody positive. So it's an average I'm talking about. So, and you know from the data that they're super spreaders, people that somebody will not transmit, and then there's someone transmitting to 20 or 30 people.
That's right.
And so we're trying to look at that. We're trying to also leverage on technology. We're trying to develop an app and some technology solutions that will enable us to know who you've been in contact with. Part of it was used, I think, somewhere in Singapore, the kind of thing they used in Korea. And we're looking to see if we can develop that so that the more you can target where the disease is, the better your response, and also the better for your community. I mean, I know people are really agitated about the lockdown, and it is quite difficult. It's a difficult thing to do, to stay in one place, not go out. This is coming to the 2nd month. So we have to better target our strategies so that we don't lose the people, as it were. We need their cooperation to social distance. We need their cooperation to stay at home and not move around and not go to places unnecessarily. And when they understand what is going on, then it's better. So we're trying to use all the tools at our disposal to better target this response.
Doctor, talking about technology, you know, that's something that I get really excited about.
Yes.
Can you? So there's a strong belief that there's so much that technology can do in this space, but traditionally, we all know that government doesn't have the internal capacity to quickly build and turn around technology to rely on partners, and this is everywhere in the world, not unique to Nigeria.
Right.
What are some of the ways you're so we've seen in Lagos State, for instance, we've seen what Life Bank has done with the Nigerian Institute for Medical Research. We actually built the app for that whole process where every test that is being done is documented on that app. The app does an initial check to ensure that all the information and data collected on each of those people being tested are properly vetted, because people tend to give fake information in the process. But in the case of that, now, what are some of the things that how are you leveraging relationships and partnerships to build or leverage technology in the fight against this pandemic?
Okay, so we've had a lot of enthusiasm, in fact, even from the public. A lot of people have written to offer, apps that they think can work. We're evaluating all of them. We have UNFPA have also supported to develop an app, but these are apps that you have to interact with. So it's only someone that wants to engage and that will fill that app and do the questionnaire and tell you where he is and what. Then there's a company called Eureka Africa. And we're working with them, and the NCDC also has a platform which is called SOMAS, which that gets that data. So we're trying to see how we can take it further with Eureka Africa to look at, for example, if I go to a place, I don't mean to. I turned COVID positive later on. I can't remember sometimes all the places I've been to. All the people I've been in contact with. And we want to leverage on technology where who has been close to your phone, if you had your phone with you, who was in the vicinity of your phone and your SIM card, to say, okay, I went to the bank, I went to the ATM, I went to the market, and these 10 people or so were near me. And we can now to contact those 10 people and say, oh, look, somebody has been exposed and we may need to test you, or we may need you to self-isolate and let us know if you have symptoms. And then in conjunction also with the app that you yourself, other people can interact with and say, okay, I believe I have symptoms. You do the self-administered test, isn't it? There is a self-administered questionnaire.
Yeah, which is triaging. Yeah, you do triaging.
Yes, yourself, and then you contact the relevant people to come. So we're looking at all of those, and we have a robust technology team as well. The Chief Information Officer of the state is looking at all of those so that we can see what can add value to what we're doing. And then in addition, we have there are so many times that we've used technology to go and do, for example, monitoring and supervision, and you fill in the geo coordinates. So we're using that. We have an app that was developed in-house for the points of entry. The cars coming in, the number of people, getting a track on them. And it was a free app that someone developed for us, and we can say where the car is going from there. And we look at it. So we're looking at all of them. There's a lot. Everybody has a lot. So they be patient if they've sent in and we haven't said anything. We're just trying to look at what works best and what we can come to.
I can imagine. I had the same conversation with the Commissioner for Health in Lagos State.
Yes.
And I think one thing that it did was actually to set up a parallel think tank that is looking at some of these issues, because I can also imagine that you're inundated with a lot of offers, people offering to help, and that in itself is a full-time work.
It's itself.
It's a full-time work itself. Doctor, you have a strong background, and I'm pretty sure you appreciate the role of research.
Right.
And we've not been investing enough in research. How do you see how do you see us completely managing this pandemic without totally relying on knowledge from other people? But also, how do you see us leveraging this pandemic to improve attention that we give to local research, not necessarily even clinical research, but also some behavioral research, for instance, in terms of how do our people behave, things like self-medication, things like stigma, for instance, even things, one that I particularly worry about at a time like this is death record. For instance, where we record number of deaths, I don't know if Kaduna is different, but I don't know of any state that does it on a real-time basis, where every 12 hours you can see how many people died in a particular location in Nigeria. And those kind of things empower people like yourself to be able to lead. But if we're not investing enough in them, is that not a disaster? And what are we learning from this pandemic that can trigger attention towards research, especially in public health in Nigeria?
Okay, thank you. The Emergency Operations Committee has a research pillar. It's one of the pillars we have. And from the outset, we set out, they've been looking at what they could do, operational research on what is happening on real time, on the KAP studies. We have thought about that. What is the studies about, people's mental state?
Yeah.
As a result of just the lockdown, and also in our patients themselves, in our patients that we're treating. How has the treatment is very lonely. The disease itself is very lonely. If you suspect, you should have you're asked to self-isolate, and then if you turn out positive, you're still isolated and treated. So it's quite a lonely disease, and not many people can cope. And then we're looking at what are the simple clinical presentations that people are coming. What we found is a lot of our patients so far, we've had only 5 fatalities so far. That most of them actually have mild disease. A few don't even have symptoms. They are contacts, and we took their samples, and we found that they were positive. So why we're trying to find out why this is.
Yeah, you're back. I don't know if it was my internet or yours, but we lost ourselves for a few seconds there, but you're back now. Okay. Yes.
There's also this multi-sector trial that is being led by WHO. I think you've seen it in the press. Kaduna State is one of those states, and it's looking at really the treatment, more about the treatment. This disease is new. People are trying different things and different protocols, and I think one of the things that is looking at is what is the treatment protocol across centers. And we're discussing with them. We've agreed. We've gone to the stage of appointing.
I'm not sure if it's my connection that is acting up, but I think we've lost connection again, Doctor. If you're on the line, and okay, Doctor, you're back now. You're back.
Yeah, sorry, I don't know where you lost me.
We were talking about the trial and the fact that the WHO trial and the fact that the
it's multi-central. We have 3 treatment centers right now. So we're following the protocol. It hasn't taken off yet. That needs also national coordination, because this is a trial that involves different states in the country to look at what we will do. So, and then we're looking at the approved drugs and the approved treatment protocols. But it hasn't started yet, but it's in the process of going on. The ones I mentioned to you about behavior and that we're doing locally, that we have got ethical approval for, and it's rolling out Yes, that we're rolling it out, mostly around operational issues and also around behavior. That's one we're doing. And it's
How
very
how is that how is that being funded, or is it being conducted internally?
Yes, the UNFPA is supporting to fund
Okay.
some. We're doing
Okay.
some
Okay.
internally. They're not large scale trials because you see we don't have a lot of patients yet, but we're starting off, and there have been some indications from other organizations that are willing to support that. So we're exploring all those, and then we will.
Okay. Thank you, Doctor. I still have a few more questions, but I'm going to announce to those who are viewing, if you want to ask questions, please use the question feature. There's a button that you can use to ask questions. I won't be able to take questions from comments, but now you can ask your question, and I'll start to take questions in probably about 5 minutes. Doctor, one thing people don't talk often about with this pandemic is the fact that there's still public health needs by citizens, right? Kaduna State, for instance, is said to have some high prevalence of severe acute malnutrition, for instance. There's also neonatal death, which is something that you've been, I'm sure your ministry has been dealing with before now. The demand for health care in those areas will not wait for COVID. How are you managing or balancing all these requirements than the pandemic at the same time?
Okay, so we recognize early on that this is probably something that will be long drawn out. The way it's going, it may take months, it may be longer than that. And what we did was to review our operational plans of what we had already planned to do this year. We had done an analysis at the end of last year, looking at our indices and doing a bottleneck analysis to find out what were the constraints to service delivery. What were the reasons why we were getting certain indicators? We did improve actually in malnutrition, ironically, but for others we didn't do too well. So we already had an integrated micro plan of how to tackle this, how to do outreaches, how to increase access to service. And what we did was to review that plan in light of what we are facing now, and how we can get those plans rolled out. So all our facilities, we have, of course, we have reduced things like elective surgery, big clinics because of social distancing and all that. But we're running services, vital services like immunization, like deliveries, looking at emergencies, of course, emergency surgeries if they need to arise. And what we've tried to do is to establish some form of triage to protect our health workers and also to quickly pick out people that may be infected and isolate them and treat them. So we're looking at those plans. We've started the outreaches. It should be a bit better because people are at home. So now we can get them as opposed to being in the farm or being somewhere else. So the plan there, we're following it up. We're looking at doing monitoring of services, which we're doing now to see that where are the gaps, where are the facilities having challenges. And also we're incorporating this into our communication plan. We've had a robust communication plan for COVID. And part of it now is to also tell people that, look, if you're ill, you need to go to the clinic. The facilities are open. If your child is due for immunization, we're still running immunization services. We're doing antenatal and all that. So the communication plan has also taken that into consideration. And we're rolling that out as we're going.
And do you think that is getting out to our people? Because in my team, for instance, there are two young men. This is a big coincidence for us, actually. We're still trying to wrap our heads around it. Two young people that my organization is sending to sponsoring to university.
Yeah.
Both of them came back in the last 2 weeks. One, the dad died of typhoid just because they couldn't go to the hospital. The other, this is just still, we can't believe it. The other died of heart attack
Oh.
because they didn't get approval to go to the hospital. Of course, these people are in Lagos. Do you think the information is getting to our people that, despite COVID, they can still get support, for their healthcare needs at a time like this?
Yeah, well, we're trying to make sure that we use all channels of communication. So one of the things we did with communication for COVID is to activate all the community actors, board development committees, the volunteer health workers, the NGO groups that are working in health. And we did sort of like a step-down communication training. What is COVID? What you should do? What are the issues? And it's through these same channels that we're trying to actually engage people in the grassroots. Radio is one place that we've also done a lot of work, maybe not so much TV, but we've done a lot of radio phone-in programs. We've sought for feedback in facilities that, if you go to a facility and it's not working, please let us know so that we can also activate our own monitoring systems to make sure that we check in that facility what is happening and why they're not taking in patients. But I think most people generally also feel that the shutdown is for everywhere. They feel no banks, no markets, no school. So some people also think, oh, okay, maybe the hospitals are not taking people, because we have reduced the traffic. One, to stop infection, possible infection, and two, to, our culture, people go and visit everybody in the whole.
I think we're having network. The call can hear me. Sorry, we lost the commissioner. Can everyone on the call still hear me? If you can hear me, please let me know. I've tried to activate this question button. I'm not sure why. If you can see the question feature, also let me know. But if you can't, feel free to put your question into comments. I'll have to struggle to scroll through them. This is the point where I'll be taking questions. So if you have questions, please do put them in the comments. Welcome back, Doctor.
Yeah, thank you. It logged me out for a minute.
Yeah, well, everyone is on the internet, so this is understandable. We're all on the internet, yeah. So, how are you dealing with disinformation, or whether we call it misinformation at a time like this? Because we've seen cases where, celebrities and people with opinions, with a lot of followers, actually also saying all sort of things that COVID is not real, it's not for us in Africa, it's for the rich, all sort of things. How are you dealing with that in the process of trying to also educate and enlighten people on how to take things?
So I think the best way to deal with that is to give the facts. We've tried very much to be ahead of the information, to make sure we're transparent with what we have, the number of cases. We've tried to talk about the demographics. We've tried to talk about, for example, the incessant traveling in and out is one of the issues. And we've tried to highlight that most of the people that have come in are people that have been traveling and breaking the orders. The other thing also is to try to have as many engagements with the public as possible. Like I said, we're prioritizing radio. We do engagements, of course, on the social media, but the audience is reduced. The audience that we're really trying to reach are those people that are in the communities that possibly cannot understand why we're asking them not to go to church or go to mosque or market or in fact even stand 6 feet away from someone. They can't get it. So we're trying to make those communication channels and give them the facts. We have some call centers. We try to do that. We have toll-free numbers, but it's something that you have to constantly keep going, and the amount of information in the media that is sometimes questionable.
Absolutely.
But people just believe, oh, I saw it on the internet, so it must be true. So it's just something that we have to keep giving the facts, making people understand, and trying to counter that with the correct information. And this is new. Of course, there's bound to be a lot of different theories about why COVID, about why it is it even serious or not. But I think the best way to tackle that is just to make sure you give the correct information.
One more question before I start to take questions from the audience. So you said this is new.
Yes.
What's your opinion? And again, I call it opinion because I guess a lot of the research is still being done. What's your opinion on why this is not as widespread in Africa as it is in say Europe, for instance, or in the US? Or do you think it's just the fact that we took action early, or is there any other reason?
I'm not sure that. I think we haven't seen the peak in Africa yet. If you look at the evolution of the disease, you can see that it came to our shores fairly late.
That's right.
Compared to what was happening in other places. Of course, the measures we took, the stopping of travel intercountry, interstate, and all that will reduce it to an extent. But the measures we take going forward to make sure that we're observing those public health advisories is even more important. Like I said, for our own cases, I'll talk about Kaduna. For our own cases, we've had fatalities. Yes, three of them are actually before the test results came out, and those three were elderly. They were all. There was someone that was over 80. A couple over between 70 and 75. And they had underlying conditions. We haven't had a young person with a fatality, and most of them had those. And like I said, the cases we see are mild, mostly, and a few asymptomatic. But that doesn't mean that as we see more numbers, we won't get that demographic coming in. And also, as we test more, we'll pick up more cases. Definitely.
Yeah. Well, there's still issues on testing, but I won't go in there now because we're losing time. There's a question here, which I don't know if you can answer. Someone says, when do we expect to go back to normal? We don't even know what normal will look like now. But I don't know if you can answer that question.
Well, we expect to go back to normal with the science. The science will guide when we will be normal. But I think we all agree that there's a new normal. And even when we don't have cases, our normal the new normal would be physical distancing for some time to come, personal hygiene, frequent hand washing, making sure that we're observing respiratory etiquette. And then also, if you have symptoms, you declare, you get tested, and we exclude COVID. Like we said, COVID does not move. People move. So we those will be our new normal, and of course the mask, the wearing of the face mask in public. So I think if we can adjust to that and keep to that, we can start moving towards getting back our normal activities. But as things like congregations are still a bit of a way away. We saw that the tests, the cases came down in China when they took those extreme measures.
That's right.
Cases where they're taking the measures, the cases are coming down. Eventually, it will go, We're not sure when it will come back because we have a large proportion of people that are vulnerable. It just needs 1 or 2 people to reintroduce it, and then we go again. So the science will guide us, but we also all have to play our own part, making sure that we're observing those public health rules.
Yeah. There's an important question. I think you've tried answering some part of it, but I just want you to shed a bit more light on it, because this is an important question, not only for Kaduna, but the whole of Nigeria. So this person says, how are you working to keep low-income community informed of the all COVID issues, since majority won't get the idea of whatsoever technology you might come up with? So I guess, there's 2 sides to that question. One is information. The other is on the end of the kind of technology you talked about earlier, which help to alert people if they are in close proximity with someone that has the virus. For instance, how do we ensure that where we have a lot of low-income communities, that this information will also get written? I know you've mentioned radio, but is there anything else that you're doing that you probably want to shed more light on?
Yeah, the community engagement, the face-to-face interaction, and of course the radio. And of course, we have a large, even though low-income communities, we have a large number of people that own phones. So we have been sending messages to phones as advisories, apart from not SMS, voice messages. And some of them are recorded by the governor himself. So as someone that has the badge of recovering from COVID, we've had other people as well, members of the cabinet, other people recording messages and sending them as short messages to people and asking them to dial in to get some more information. But really, we're prioritizing this community engagement with our community actors to make sure that they are talking to the people at the grassroots about what is happening, about what COVID is, what they should do to protect themselves, and what they should do to protect their community. Because a lot of the leakage we're coming with, people coming in, are people that are coming into the border communities. And some are friends and relatives, and they just don't know what the fuss is about. So we're trying to engage them to understand that someone comes in from an infected state, he may not have symptoms, but while you're around him, you can get those symptoms and things like that. So it's more face-to-face engagement that we're trying to do as much as possible.
Absolutely. Dr. Baloni, I know we're coming down to, we have probably just seven or 8 more minutes left. People want to support, not only in Kaduna, everywhere in the world. Everyone is coming together to say this is a pandemic that we all have to deal with.
Yeah.
What are some of the areas that you think you're still struggling and you could use support with? Instead of people just bombarding you with expression of I don't know how to put it now. That is not really where your pain lies. Where are some of the areas that you think you can use help at a time like this?
For a minute, but I think I got the gist of the question. I think
I think the connection. Yeah, I was saying, where are some of the areas that you think you can use help? A lot of people are throwing support to people like yourself, to states, to leaders, but some of them may actually be a distraction as against being support that you need. But what are some of the pressing areas that you think you can use help at a time like this?
I think the greatest area that will need help is for individual responsibility. I think the whole citizenry need to own this fight against COVID. We need people to understand the advisory and to put it into practice. I think it will help much more than, yes, of course, we need equipment. We know there's a global shortage of PPEs. We're still making efforts to do that, equipment to treat, ventilators, things like that. But unless all and collectively, individually and collectively, we take personal responsibility in making sure we're observing those. They're very simple, actually. Is that physical distance? Is that unnecessary moving in crowds and going to places where you have the infection? Is washing your hands frequently? Is observing respiratory etiquette? And also personal responsibility with your health. Make sure you eat well, you sleep well. It's very challenging times. Most people, when they're working, are looking for time to sleep. Now we have all the time to sleep. We're not sleeping, we're doing other things. Sleep, sleep and, eat well, do a bit of exercise and talk to people. So it's a fight we all have to win together. It's not just for health workers or just for the press or just for the government. It's everybody. We can all get affected, and we need to be our brother's keepers and make sure that we do that. On the things about the equipment, yes, we're always open to it. What we're trying to do in Kaduna is to build the health system. So we're trying to see with the health system that we have, where are the places where we need to support the health system itself to respond long term. If it's no COVID one day, there will be other things that we need to respond to. So we're looking at when we're buying this heavy equipment, what we can put into use, what we have existing, what we can put into use. In terms of isolation units, we have, yes, 2-3 designated places, but we're looking also as going forward to have an isolation unit in every health facility. For example, a secondary health facility, 10 beds, 20 beds, 30 beds, depending on the population, so that we don't have to start moving people from where they are. The facility there can manage the cases. We don't have to start moving people. And then people that are complicated, of course, we'll move them. And then we're investing in a bigger center, which we've already started building. And we hope it will come on stream in another 6 weeks. To have a specialized center for more severe cases where we can. At the moment, we're using the tertiary institutions. Tertiary institutions we have in the state in collaboration with them, and trying to get this response in a collaborative way, so that we can engage with it.
Doctor, just in that, you mentioned, before we wrap it up, I don't think I'm seeing more questions. Well, a lot of people are saying kudos to you for the fantastic work. We all know how difficult it is at a time like this. You mentioned something on PPE. We have only just 1 or 2 minutes left. There are so many people out there now trying to produce PPE locally. What are your thoughts around what you find acceptable, and if people can be of help there, what precisely would you think appropriate support would be around PPE?
Okay, so we have DICON Defense Industries Corporation in Kaduna. We've collaborated with them, and they've produced PPEs which we're actually using. They did some extended testing on the material to make sure that it was up to standard. And then they've been producing for us, and we've been buying from them. So I think for me, if we can get locally produced PPEs, very good, but we also have to be mindful of the standard. What part of the constraint is that a lot of the material has to be imported, even for them to make it. So that has been a bit of a constraint, but the DICON one we're using them. They've produced face shields, they've produced boot covers, head covers. So we're collaborating with them. The only drawback, like I said, is that it has to be of standard, because these involve people's lives.
Absolutely.
Making sure that we don't put them in.
Absolutely. We're gonna be kicked off. I just want to make sure I say thank you so much for taking out time, and I wish you well with all your efforts in protecting our people.
We really appreciate your support and time at this kind of time. So thank you so much. We will be kicked out soon in like few seconds.
Thank you.
Thank you.
Thank you. And thank you for listening and having me. Thank you. Bye.
Bye.